So next we have Dr. Dinesh Kalra, who's going to talk to you about Fabry and the heart. Casey?
Well, as Jerry said, we have Dr. Dinesh Kalra joining us. He is the Chief of Cardiology at the University of Louisville Medical Center and a professor of medicine and radiology at the School of Medicine. He sees both adults and children with Fabry, and I got a chance to peek at his presentation. It's really great. He's telling us about each and every test your doctors might recommend, what it's like for you, what the doctors see, and I think he might even be able to answer a question from that side of the room. So we're so happy to have Dr. Kalra here with us, our cardiology expert today.
Thanks, Casey, for that kind introduction, and thank you, Jerry, and to the National Fabry Disease Foundation for inviting me here. This is my first meeting, and I was surprised to hear there's been 14 meetings. I've missed 13 of them, and unfortunately today I'll miss camp because my flight leaves early this afternoon, but I plan on making this a recurring event. And the reason I say that, I'm just so amazed at the amount of energy in this room. One of the things I always tell my patients is be empowered, learn about your disease, and I see that on full display here. I mean, you guys are amazing. Or I should say you guys are fab, right? So this is especially important because, as you'll notice, if you don't stand up and speak for yourself, I do a lot of advocacy on the Hill and in my state of Kentucky, you won't get heard. So you have to speak up. And to me, this bidirectional exchange, I'll tell you about heart disease, but it also gives me an opportunity to learn from you. And this interaction where pharma comes here and wants to hear about your experiences, that's how we make innovations. So thank you so much, Jerry, and for everybody else, Hannah, Casey, for putting this together. I'm really delighted to be here, maybe even more than you guys are, so thanks. So I have a couple of slides. I try to find a balance between being too technical. I've given this talk to cardiologists before, and I wanted to, as Casey said, keep it somewhat at a patient level without getting too into the jargon, medical jargon. So I'll give a little bit of introduction. Some slides may be more technical, but I hope you'll still find value in them. So what is Fabry? It's the second most common lysosomal storage disease. You might see a little bit of different statistics in some places. In some places it might be the most common. The more we look for it, certainly the more we are finding, which may be part of the reason. And I try to sprinkle my talks, not intentionally, but some of these are questions on your crosswords and your raffle things, so pay attention. Named after two dermatologists who discovered this disease in 1898 separately, obviously Johannes Fabry and William Anderson, who was a British dermatologist, and they named it after the classic skin findings, which you've seen pictures of, the angiokeratomas. Now, as all of you have heard by now, this is an X-linked disease. That means it is transmitted by the gene that resides on the X chromosome, and that's why you have differences in the prevalence or how often you see it in the population. In males, the classic form is found in 1 in 40,000, but again, these numbers are changing a lot. For example, when they do newborn screening in everybody, in some places like Taiwan, they have found this incidence to be as high as 1 in 1,600. And some of these differences relate to whether or not you're looking for the classic type A, severe phenotype, or you're also considering the type B, the milder phenotype that is restricted to one organ only that occurs somewhat later in life. So don't be hung up so much on the numbers. We know it's a rare disease, but maybe not as rare as we thought it used to be. One thing we do know for sure is that a lot of physicians have a gap in the knowledge of this disease. I know you have shared that when you take your child or a relative to a doctor, many of them, especially in general internal medicine, may not have heard of this disease or seen patients before. So it's really important that if you think you're not getting the answers from the physician, to keep pushing and to go to a specialist. And the reason that is important is the earlier you diagnose a disease, the better the outcomes. And we don't have solid data for every organ system. You saw data that if you start therapy early, you do slow down the progression of kidney disease. We have data for heart also. But it's true that once a disease becomes later, when you diagnose it, the less chance you have to impact the outcome. So if somebody's already had a stroke, or somebody's already had a lot of fibrosis in the heart or in the kidneys, there's been a lot of damage, and the patient starts treatment at age 50 as opposed to starting treatment at age 20, you've lost 3 decades of making a contribution to slow the disease down. So that's why it's really important to diagnose the disease early and start treatment early. Otherwise, you see, as you see in the graphs at the bottom, there is a loss of life expectancy in Fabry when people are started on treatment later. I won't belabor all the signs and symptoms of the disease. This is a publication we put together for cardiologists a few years ago. I'm going to focus only on the heart, but you've heard from the prior speakers, and you'll hear much more in detail from the other speakers later about the involvement of different organ systems. What I will say is that none of these symptoms are classic enough where if you take 3 or 4 symptoms to a doctor and say, all right, this child had pain crises growing up, and now they have some trouble learning and they're having GI symptoms. None of those are specific enough to a physician who's not a Fabry expert to jump on the diagnosis. And that's really a challenge. It requires a very high degree of suspicion from a physician who's heard a lot about this or trained in this field to say, aha, I need to test for Fabry. So once you think of it, arriving at the diagnosis is relatively simple. But the block really occurs that most physicians haven't seen this constellation of symptoms. Dr. Google won't assist you if you put those 3 symptoms in to say this is Fabry. So it does require, for the de novo patient, that the physician be really well informed. And so one of the things we try to do is educate our physicians and our communities of, think about this sort of disease and other rarer diseases if you have this constellation of symptoms. Some things are easy to recognize. For example, the cornea verticillata. When you see those, there's only a few differential diagnoses, but the other things can be really challenging, especially the cardiac symptoms, as I'll tell you in a bit. So the reason I put this up here is just to show you what's going on the right. You'll see cardiomyopathy, which is the ramp that you see on the right in orange. Fortunately, doesn't start very early on. It starts usually in the teens in the classic form, and typically in the 30s or 40s in most individuals. And so what that means is the heart, if you start treatment early on, say at age 10 or 15 or 20, there's a good chance that folks will not develop many of the cardiac complications. Unfortunately, many of the people that I see in my clinic, and I probably have 40, 50 patients over the course of the years that I've taken care of, they do have cardiac involvement. And what that means is, for whatever reason, they weren't started on treatment early on, or they weren't put on all the cardiac drugs that we have to prevent the progression of disease, and so they do tend to land up having some form of heart disease, especially as they get older. The other thing I should mention is heart disease is really common as people age. So after the age of 50, a lot of people, even without Fabry disease, will develop stiffness of the heart because of high blood pressure, for example, or they'll start having some degree of blockages in the blood vessels of the heart. So it gets really hard to tease out in somebody who's age 60 as to what is the contribution of Fabry only in the heart disease in this patient, as opposed to what is the contribution of other common diseases such as high blood pressure and cholesterol and being overweight and not being healthy. So both of those things compound each other, but if I see Fabry patients early on, I can generally put them on preventive therapy so they won't develop heart disease early, as many of them are prone to have. So what are the common symptoms in Fabry disease? So if somebody has Fabry, what should they be on the lookout for? So the most common symptom is dyspnea, or what we call shortness of breath. Now, Do I get short of breath if I run 4 miles, 5 miles? Sure. But this is an inordinate amount of shortness of breath. So folks generally know, I used to be able to go up 2 flights of stairs, and now, I go up only half a flight of stairs and I'm feeling short of breath. So something has changed. The best indicator of whether or not somebody is short of breath is asking the patient. Obviously, we have blood tests. There's a blood test called an NT-proBNP. It basically tells me if the blood pressure in the heart is elevated. That can assist, but I often ask patients. So folks who are short of breath should think about heart disease. This is, again, not specific to heart disease. Shortness of breath can also arise from lung disease, and you heard that Fabry can affect the lungs also. So some of these things you have to put in the correct bucket and see, maybe it's a combination of 2 organ involvement, but typically dyspnea in patients with Fabry generally spurs me to do additional tests, such as an echocardiogram. The next most common symptom is chest pain. Now, I see patients with chest pain every day, and a lot of those have to do with blockages in the heart, but patients with Fabry can have chest pain even without blockages in the heart. And you say, why is that? I mean, if I don't have blockages in the heart, why am I having chest pain? It's because the small blood vessels in Fabry, both in the heart, in the skin, in the brain, they tend to become narrower because GB3 deposits in the lining of those blood vessels, so-called the endothelium. And when the endothelium, or the lining of those blood vessels, gets affected, those blood vessels can't dilate or relax in response to stress. When your organ needs more blood flow, for example, when the heart's exercising. And that's why these folks can develop angina or chest pain even without having blockages. That's a condition we call coronary microvascular disease. The microvascular refers to the small blood vessels that get diseased. And that's why we see individuals sometimes in their 30s or 40s who have strokes and heart attacks. They don't have blockages in the big pipes or the big arteries, but they have blockages in these tiny blood vessels because of deposition of GB3 in the endothelium of those blood vessels. Then we'll see a lot of palpitations. Many times this is from skip beats, but as Dr. Hopkin told you, this can be from slow heart rate too. So when people have slow heart rate, each heartbeat is more forceful. They feel that sensation, and that's called palpitations. Arrhythmias are very common as people get older. I'll talk specifically about an arrhythmia called AFib, which is very common in people, and what we do for that. Lightheadedness or dizziness. Somebody mentioned POTS earlier. POTS is when people feel that when they stand up, their heart's really racing. So their heart rate at rest will be 80, and then within a minute or two of standing up, it'll be 150. So it's typically the tachycardia related to posture, but they also feel lightheaded, weak, tired, dizzy, and it occurs more commonly in Fabry because the common terminal pathway for causing variations in heart rate and blood pressure is your autonomic nervous system, and the nerves affected in Fabry, as you've heard, so people do get that problem in Fabry. Syncope is not very common, which is fainting, but again, that can be related to variations in blood pressure. There's another clue on your crossword about swelling in the legs. The medical terminology for that is edema. There's various kinds of edema. One is accumulation of fluid. Sometimes it can have to do with the accumulation of lymph. So the fluid that drains waste in our body, that's called lymph. So that's called lymphedema rather than just plain fluid edema. You heard a lot, and you will hear about nervous system involvement, both in the brain as well as the peripheral nervous system. So folks will have tingling, loss of sensation, pain sensation in their hands and feet, what is called acroparesthesias. And of course, people can get mini strokes, what are called transient ischemic attacks, or TIAs. Cardiac disease, by the numbers, accounts, unfortunately, for the majority of deaths in patients with Fabry disease. Somebody asked earlier if the cause of death was specific to cardiac disease, was specific to Fabry and the FOS, the Fabry Outcome Survey, but cardiac disease remains the most common killer, both in patients without Fabry and in patients with Fabry. The incidence is threefold higher than in the general population. Arrhythmias, as you heard, are very common, and everything that I'll tell you is more common in men than in women. 60% of people experience angina from the coronary microvascular dysfunction that I told you about, and about half of the men will have some sort of cardiac event by the time they get into their third and fourth decades, and that could be things like heart failure or heart attack or arrhythmia. So it is very common for me when I evaluate patients to find some evidence of cardiac involvement. Sometimes it's not overt, so they may not know about it, and then I'll tell them, listen, your echocardiogram looks abnormal, your MRI looks abnormal, I would like to start you on treatment, and I get pushback. But that doesn't mean that if they can't see the disease or they're not aware of the disease. I'm looking at the analogy of the cat. In the cat, you can look at both the tones of fur. In a human being, unless you do advanced imaging of some sort, sometimes it's really hard to see if the organ is involved. And so current treatment guidelines say any form of organ involvement, whether you can check it by blood test or imaging, requires treatment rather than waiting for symptoms. Symptoms sometimes are the tip of the iceberg. We don't tell cancer patients, listen, I found a mass in your pancreas, but you feel fine, so I'm not going to treat you. We start treatment. So I try to use that same analogy for patients. If we detect disease that is subclinical, it still warrants treatment. Now, I thought this was too simplistic, but I wanted to show you some pictures. Obviously, the EKG is a standard test everybody with Fabry gets, but many of my patients get so-called event monitors, or Zio patches. These are sticky little patches that record the EKG 24/7, and EKG lasts only 10 seconds. So if you're having symptoms once every 2 months, I can't follow people around at a home with their EKG machine. This allows me the ability to do that. It's a wearable patch that gives me EKG 24/7 and then transmits the data to me, or you peel it off and you mail it to me and I download the data so I have your 24/7 EKG for the time you wore it. So 2 weeks of EKG wearing gives me a lot more information than 10 seconds of EKG. An echocardiogram is a universal test for anybody with heart disease. This is a simple ultrasound. We do stress tests often in patients who complain of chest pain or they feel like they're tired and they can't catch their breath. That's a good test to objectively measure that. Sometimes I'll do cardiac CT scans to look for blockages. I do MRIs in a lot of my patients. I'm an advanced imager, and what that means is we do sophisticated imaging tests to pick up disease even before it is clinically manifest. And rarely, some people will need an invasive test, and that's called a heart catheterization. So this is an echo. It's a simple test. A lot of women have echoes when they're pregnant. It's the same principle. Use ultrasound to make pictures. And so this takes pictures of the heart, and the ultrasound beam, as you'll see, is able to go in a plane. This is painless, it's not dangerous, and takes pictures of moving organs such as the heart, and you're able to see all the chambers of the heart, the valves, and you're able to assess the function of the heart. Sometimes, not often, 10 or 20% of people won't have good images, either because there's breast tissue or there's fat tissue, and so we may need to start an IV during the test and give a little bit of contrast. That's a safe contrast. It's not the same as the contrast you get during X-rays, and that can take better pictures of the heart by making the walls more apparent, and that is called definity contrast. We often measure the thickness of the heart using ultrasound. An MRI is a more sophisticated machine. An echo takes only 20, 30 minutes. An MRI might take 45, 60 minutes. You're in a tube. So for people who are claustrophobic, sometimes we'll give them sedatives such as Valium before we put them in the tube so they can tolerate it better. There's a lot of please hold your breath and keep it held for like 45 seconds. So people who are very short of breath, they have trouble getting an MRI. Other folks who can't get an MRI are people who have nerve stimulators or they have a clip in their brain. Any metal is pulled by the magnet of the MRI. The MRI is very, very powerful. It's got the magnetic field of 30,000 times the strength of Earth's magnetic field. The most powerful magnet you can imagine exists in the MRI machine. It's always on, so there's no way for me to turn it off and put you in the machine and turn it on. It's constantly on. So if you go in and you mistakenly take your credit card or phone with you, it'll fly to the MRI machine. And so we don't do it in people who have metal, but a lot of metal is okay. Medical metal that's intentionally been put in, such as a hip replacement or a pacemaker, many times we can do it, especially today's pacemakers, we can commonly do MRIs. And you get these beautiful images of the heart where you can assess a lot of things. This is what MRI images look like when we process them. We're looking for things such as scar tissue in the heart, because that tells me there's been damage to the heart muscle, and we can pick that up with the MRI. This happens even before people are aware. They may be asymptomatic, and we can still detect it. This is what the event monitor looks like. It gives me an EKG recording for a couple of weeks, so I can look for atrial fibrillation or bradycardia, which is a slow heart rate. But best of all, I can correlate people's symptoms. So if someone tells me, oh, I was lightheaded 3 days ago at 8 p.m. after I had dinner, it allows me to go and look at the time and tell me what the heart's rhythm was at that time, so I can make that correlation. If the heart rate was slow at that time when people felt dizzy, I might give them a pacemaker. If they were having a bad heart rhythm called ventricular tachycardia, I might have to give them a defibrillator. So this gives me objective data. This is what a nuclear stress test looks like. Those bagels being cut on top show me the blood flow to the heart. So if somebody has a blockage, or their heart's not getting enough oxygen or blood when they walk or run and they're having chest pain, this test will show me if they're getting blood flow to the heart or not, and then I can make a determination as to what medications to treat them with. This is a catheterization. Most people don't have to undergo this, but if I suspect somebody has blockages, we'll put a catheter in through the artery in the groin or the artery in the wrist these days, take that up to the heart, use x-rays and inject iodine dye to see the blood vessels. And once we see the blood vessels, we know if they're normal size, if there's fatty deposits from cholesterol, and be able to treat those with a stent if needed. Now, the age of cardiac manifestations, as you heard, most people will have some sort of heart disease symptoms start in their 20s, 30s with the classic form, but with the delayed forms, that may not occur until the 40s or 50s. What are the main cardiac manifestations? You've heard a lot about this. Thankfully, valve disease, shown on the left, is not a big problem in Fabry. When people do have valve disease, it's generally mild, moderate. They don't need valve replacements. What is common, as I mentioned, is chest pain from microvascular ischemia, thickening of the heart muscle, and that thickening of the heart muscle produces something called HFpEF, or heart failure with preserved ejection fraction. And people get short of breath, and we treat them with medications for that. The next, shown in green, is all the arrhythmias that can occur with AV block, which is the heart doesn't conduct electrical impulses as well, so people may need pacemakers, and that slows the heart rate down. And then the HFpEF portion that I already mentioned. Again, this was intended to be for physicians, so there's a lot of percentages here and all the symptoms and manifestations that can occur. But I think we've already talked about a lot of this. By the way, these slides, for anybody who wants this, and I think the recording this will be available for folks who think this is too simple and you want more details, you're welcome to have these. This is what the echo looks like. The heart muscle is juicy or thick, and because it's thick, it doesn't relax very well, and the blood pressure in the heart goes up, and that's why you get shortness of breath. Not everything that's thick in the heart is Fabry. Sometimes it can be other diseases, and that's where the MRI really helps us. I think I'm running short on time, so I'm going to skip over some of the slides that are too technical, and we'll go to the end. This is what EKGs look like in Fabry. The voltage is high, and there's other problems, as you heard, with bradycardia. The pathophysiology of cardiac disease is well studied. It's got to do with inflammation and then scar tissue formation, so-called fibrosis. And when we do biopsies in the heart, we're able to see the scar tissue, shown here in that light tan color, as well as these inclusions, so-called these onion rings that we see inside the cells, which are accumulations of GB3 inside the cells on electron microscopy. We look at patients and we classify the stages of cardiomyopathy, and then we determine if somebody is very early, how do we treat them for heart medications, as opposed to somebody who's further along in their disease process, we'll be more aggressive with treatment. So As you heard, we do cardiac workups roughly every year in people who have symptoms. If somebody has no evidence of cardiac disease, then I might do an echo once every 5 years. But once we see some signs or symptoms of heart disease, then they'll get an echo, EKG every 6 to 12 months. I talked about when to treat. Any signs of cardiac or renal disease warrant treatment, or cerebrovascular disease, CNS disease. Cardiovascular therapy is control of blood pressure with medications such as lisinopril, valsartan. These are ACE inhibitors, angiotensin receptor blockers. Sometimes we'll use beta blockers like metoprolol. And these drugs are good not just for lowering the blood pressure, but for helping heart failure and for stopping protein leakage from the kidneys, the proteinuria. And if people have arrhythmias, they'll get pacemakers or defibrillators. Sometimes we'll have to do ablation, which is taking people to the cath lab to burn portions of the heart tissue that are causing the arrhythmia. I won't go over all the therapies we have. I think you have heard about them, and I won't spend too much time talking about the approved therapies, but this slide gives you a clue. There was a question as to how many approved therapies are there in the US. You know, there's 3 approved therapies, 2 enzyme replacements, and an oral medication. So in conclusions, Fabry is a rare disorder with multiple organ manifestations. Cardiac symptoms are very common, related to thickness of the heart muscle, strokes, MIs, which are myocardial infarctions or heart attacks in young people. Making the diagnosis is easy once a physician considers it. Cardiac disease remains the #1 cause of death as well as morbidity or system involvement. And we have many tests such as echo and MRI to diagnose and treat people early on. And there's so many new treatments that are coming to us, including gene therapy. So this is a really exciting field. So thank you so much for your attention.
I'll share one quick story. I have a long history of cardiac manifestations. So I've had all of the above. And I had 3 ICDs, the pacemaker or defibrillator combination. And after my second one, I had it for about 10 years, not a peep. And I walked my dog and I came back to the house, and my defibrillator fired 13 times in 35 minutes, appropriate shocks. And I thought that was it. I laid on the ground. The EMT team couldn't touch me because if you touch someone that's having a shock, you might get a shock. So we got through that, but in my disease progress. So I don't know if I mentioned, but I'm almost 70 next month, with classic disease, and my heart has especially been troublesome. So I got through all that, but when we wanted to do an MRI after that episode, and I didn't have an ICD that had been tested, so they call it a conditional MRI. And I was a little apprehensive about that, but I went in and I got the MRI, and one of the songs that they played while the MRI was what we were doing it, was American Pie. And if you recall the song, the words are, "And this'll be the day that I die." And that will remain in my memory forever. So, all right, so we're gonna take a 15-minute break. Please be back promptly so that we can stay on schedule. This is your last chance for raffle tickets or t-shirts, and that will all go away. And, so go take a break.